My name is Casper Nim, and I'm a chiropractor and a PhD student at the University of Southern Denmark. The project I will present now is part of my PhD project and is called Changes in Pain Sensitivity and Biomechanics in Relation to Responder Status Following Spinal Manipulative Therapy in Chronic Low Back Pain Patients, a secondary explorative analysis of a randomized trial. So initially, we designed a randomized trial that investigated whether spinal manipulation could be optimized for chronic low back pain patients. More specifically, we wanted to explore if the segmental location of the thrust application had an impact on both patient-reported and experimental outcomes. We used the pressure algometer to quantify segmental pain sensitivity and the VertiTrack to quantify segmental stiffness. Both measures apply a perpendicular pressure to the paravertebrals. One measures when the patient experiences pain, and the other one measures mechanical indentation at a given load. We then categorized each segment as being either stiff or pain sensitive. Then we randomized each patient to receive spinal manipulation at a specific segment indicated by either stiffness or pain sensitivity. And this had no impact on whether the patients improved or not. In general, we observed minor improvements in back pain intensity for both groups, which is very much consistent with the remaining literature and provides more evidence to this growing field that spinal manipulation is not affected by the segmental location, at least in humans. Interestingly, this did not impact lumbar stiffness either. And maybe even more interesting, we saw a segmental effect of increased pressure pain threshold scores for the patients who were treated at the pain-sensitive segment. This was interesting as there was no baseline differences in pressure pain threshold between the groups. However, it was not a proxy for clinical improvement, questioning whether our finding even is clinically relevant. Which is why we did this secondary analysis, looking at whether these changes of these experimental measures impacted those who did not improve and those who did improve by having a 30% decrease in disability. So in total, we included 132 patients, 9 of them dropped out, and we had 123 available for this analysis. The spinal manipulation procedure was standardized, aimed at that specific segment's spinous process in a directly posterior to anterior thrust, a total of 4 times over 2 weeks. No other intervention were given. We measured these experimental outcomes at baseline, directly after the 4th treatment, and again after a short 2-week follow-up period where the patient received no treatment. We also remeasured stiffness directly after the first treatment. This decustomization process took place at the final follow-up session, and of the 123 patients who completed the intervention, only 37% of 46 patients actually improved by the 30%, which is illustrated by the green line on the graph. Maybe even more interesting or surprising, we saw that 23% of the patients actually had increased disability following the intervention, which is illustrated by the red line, meaning that 23% actually had worse disability after the intervention. And also the graph quite clearly shows that the two groups responded at the same rate. So despite dichotomizing the patients into responders and non-responders, this did not impact whether stiffness changed or not. So we can conclude that nothing happens with segmental stiffness in this cohort. However, we could further explain our interesting finding of a segmental increase in pressure pain threshold for the pain-sensitive group. More specifically, pressure pain threshold increased in 2 instances. One was that we observed an increase in pressure pain threshold independent of the responder status, or that the patients treated at the pain segment did have an increase in pressure pain threshold, both for the responders and the non-responders. And this was pretty much consistent with our previous finding. However, we added to it that the responders also improved independent of the treatment allocation. So all the responders actually had an increase in pressure pain threshold following the fourth session. So this mechanism of increased pressure pain threshold can be explained by two parallel mechanisms. One is a localized reflex-mediated normalization at a pain-sensitive segment. So this is pretty much consistent with what multiple systematic reviews that has been published regarding the effects of spinal manipulation on pain sensitivity has suggested. That a non-specific inhibition of pain sensitivity can be observed. And also we saw an experimental inhibition of a sensitized nociceptive trigger followed by a decrease in experimental pain sensitivity. This does explain the overall improvement we saw for the responders independent of the application site, and more importantly, this is possibly not related to the spinal manipulation at all. It could be just that they clinically improved, thus their pressure pain threshold increased. So this study presents two methods of reversing deep tissue mechanical pain sensitivity or increases in pressure pain threshold, more specifically a neurophysiological effect on spinal manipulation on a discrete hyperalgesic segment with no apparent clinical benefit, and a non-specific general effect on pain sensitivity through a successful treatment of a painful condition. And again, lumbar stiffness was not affected in this group. Finally, I would like to acknowledge all the funders who made this project possible, and thanks for watching.